Senhoras e senhores, nosso muito bom dia, sejam muito bem-vindos, muito bem-vindas. É com alegria que damos início ao 25º Hepato Pernambuco Jubileu de Prata do Congresso, ocasião em que comemoramos também os 15 anos de existência da Unidade Diagnóstica do Instituto do Fígado e Transplantes de Pernambuco, IFP. Um evento que já é recorde de participantes e um dos maiores na área de hepatologia do mundo. Já reunimos profissionais de 5 continentes, destacando a presença de 150 especialistas nacionais e cerca de 60 internacionais. Serão ao todo 9 sessões no estilo Live Talks, nos meses de junho e julho, ministradas por palestrantes internacionais e com a participação de moderadores e debatedores com expertise no tema abordado. As atividades previstas para o Congresso serão semanais, todas as terças-feiras, no horário das 12 horas, horário de Brasília, local, e com duração de 2 horas através de plataforma Zoom Pro. O acesso sempre será livre e gratuito. Para a abertura desta cerimônia, saudando convidados e participantes, vamos ouvir a professora doutora Leila Beltrão Pereira.
I think I'm going to speak in English because I have some friends from other part of the world. Thank you to all my colleagues attending the Hepato Pernambuco 2021 Liver Talks webinar. It's an honor to initiate this event with my dear friend, Professor Michael Mães, with the Magna Conference. It's also a great pleasure to have my friends, Professor Arun Sanyal, Dr. Mohammed Shadab Siddiq from US, and Professor Philip Nilsson from the United Kingdom, together with my Brazilian friends, which I would like to pass this integration to Dr. Nathalie Leite from Rio de Janeiro, and also Professor Carlos Brandão, President of Brazilian Society of Hepatology, that is going to introduce Professor Mães, and the international speakers, debaters, and presenters of the clinical case. We also prepare a small tribute to celebrate the Hepato Pernambuco Silver Jubilee. Welcome to our meeting, and thank you very much indeed for everyone.
Muito bem, muito obrigado, doutora Leila. Tudo bem, vamos dar sequência, então, enquanto outras pessoas entram. Nós temos também a formalidade local e vamos ter a graça, mais uma vez, e a honra de receber, pedimos a atenção de todos nesse momento, receber o hino de Pernambuco, que abre oficialmente este evento, cantado pela artista Nena Queiroga, que a partir desse momento entoa o hino do nosso estado, recebendo todos os participantes e convidados.
Coração do Brasil, em teu seio, corre o sangue de heróis rubro-veio, que há de sempre o valor traduzir. És a fonte da vida e da história desse povo coberto de glória, o primeiro talvez no porvir. Salve, ó terra dos altos coqueiros, de beleza soberbo estendal, Nova Roma de bravos guerreiros, Pernambuco imortal, imortal. Esses montes e vales e rios, proclamando o valor dos teus brios, reproduzem batalhas cruéis. No presente és a guarda avançada, sentinela indormida e sagrada, que defende da pátria os lauréis. Salve, ó terra dos altos coqueiros, de beleza soberbo estendal, Nova Roma de bravos guerreiros, Pernambuco imortal, imortal. Do futuro és a crença e a esperança desse povo que altivo descansa, como atleta depois de lutar. No passado teu nome era um mito, era o sol a brilhar no infinito, era a glória na terra brilhar. Salve, ó terra dos altos coqueiros, de beleza soberbo estendal, nova Roma de bravos guerreiros, Pernambuco imortal, imortal. A república é filha de Olinda, alva estrela que fulge, não finda, de esplender com seus raios de luz. Liberdade, teu filho proclama, dos escravos o peito se inflama, ante o sol desta terra da cruz. Salve, ó terra dos altos coqueiros, de beleza soberbo estendal, nova Roma de bravos guerreiros, Pernambuco imortal, imortal.
Obrigado, Nena Queiroga, pela sua participação aqui com o nosso hino de Pernambuco. E nós, a partir de agora, pedimos sua atenção a todos os participantes para a exibição do vídeo em comemoração aos 25 anos do Hepato Pernambuco, que será exibido a partir de agora.
15 anos do IFP, Instituto do Fígado e Transplantes de Pernambuco, e 25 anos do Congresso Hepato Pernambuco. 2 datas, 2 motivos para celebrar o conhecimento. O IFP tem muito orgulho de participar mais uma vez da organização deste evento, que reúne especialistas do mundo inteiro. Já foram mais de 150 participantes nacionais e 60 internacionais de várias regiões do mundo, dos 5 continentes que já participaram deste, que já está entre os maiores congressos nacionais na área de hepatologia. Grandes nomes da medicina internacional e nacional já estiveram no evento, o que deixa a gente que somos os nomes por trás do IFP muito orgulhosos e felizes por saber que estamos no caminho certo, o caminho do conhecimento. E é também em nome de todos aqueles que nos ajudaram nestes 25 anos que estamos aqui para agradecer 25º Congresso Hepato Pernambuco e 15 anos do IFP. Conhecimento que ultrapassa fronteiras.
Muito bem, aí está, portanto, o vídeo que comemora os 25 anos do Hepato Pernambuco. Estamos começando neste momento e dando início à nossa programação. Nós teremos a Conferência Magna com o tema Hepatologia Ontem, Hoje e Amanhã. Será ministrada pelo palestrante Dr. Professor Michael Menz, da Alemanha. E vamos convidar como presidente da sessão o professor Carlos Eduardo Brandão, que é professor titular da disciplina de Clínica Médica, Gastroenterologia, da Escola de Medicina e Cirurgia do Rio de Janeiro, da Universidade Federal do Rio de Janeiro. É membro titular da Academia Nacional de Medicina desde 2015 e presidente eleito da Sociedade Brasileira de Hepatologia para o biênio 2020-2021. Dr. Carlos Eduardo pode ficar à vontade para apresentar o nosso palestrante e o tema da Conferência Magna.
Bom dia a todos. Professora Leila, como presidente da SBH, é uma honra estar aqui dando início à abertura de mais um 25º evento do Hepato Pernambuco. Me sinto muito honrado, muito lisonjeado com esse convite e parabenizar você e a todo o teu grupo do Instituto de Fígado de Pernambuco por mais essa iniciativa absolutamente exitosa. O nosso conferencista dispensa a apresentação, o professor Michael Manns. Ele é professor da Universidade de Hannover, na Alemanha, e um profundo conhecedor de vários aspectos das doenças do fígado, das doenças autoimunes, das hepatites virais. Professor Michael Manns, it's a very pleasure. I'm very honored to introduce you to make your lecture today about hepatology, yesterday, today, and tomorrow. Please, welcome.
Thank you very much for the kind invitation. Okay, thank you very, very much for this very kind invitation. Thanks to you and Professor Leila Pereira and all the other organizers. And it's a pleasure and honor to speak to you on the silver jubilee of Hepato Pernambuco, this time as webinar. And I also give acknowledgement to two colleagues, Markus Kornberg and Thomas Wirth, who helped me with discussions. These are my disclosures. Liver disease presents a huge burden to the public health. These are data from 2017, more than 1.3 million deaths and 41 million DALIs. And it's very important to notice that 2/3 of all potential years of life lost are in working years of life. So death and inability, disability occurs early in life due to liver disease. Now we switch again, and the times are changing. We all are aware that due to the advent of the DAAs in hepatitis C therapy, we see a decrease in the decline in hepatitis C. And therefore, hepatitis C problems changed from virology to a public health issue. I think we all in hepatology can be proud that hepatitis C is a masterpiece of translational research. We saw the advent of the hepatitis C therapy with oral therapies in 2014 with Lasker Award winners, Nobel Prize winners last year. And so overall, this is a masterpiece of translational research. Here you can see this is European data of the European Transplant Registry. And you see that there is a decline, only a slow decline, in transplantations for hepatitis C in the interferon era. While after the start of oral therapy, we see within a short time frame a decline in liver transplantations due to hepatitis C. You all are aware that the WHO defined the goals for the targets for elimination of hepatitis C. By the year 2030, there should be a 90% diagnosis of infected patients and 80% should be treated, and this should lead to a 65% decrease in mortality. However, there are surprises, and this is now the time of the COVID pandemic. There are also modelings available in the literature that the new diagnoses are decreasing, treatment is delayed, but at the end will delay our goals for achieving HCV elimination. And there are new problems. There are new problems, and this is we see in some regions of the world a sharp increase in acute hepatitis C cases, like here data from the United States. However, we still do not have a vaccine available. At least some vaccines are in development, either diagnostically or therapeutics. And we have seen a publication in the New England Journal this year, unfortunately negative. So hopefully in the hepatology of tomorrow, we will have a prophylactic vaccine. In the days of COVID, we all talk about long COVID. And we also have a similar problem of long hepatitis C. There are data in the literature that hepatitis C patients, even after clearing the virus, have symptoms and decreased quality of life, and this may be related to a long-term deterioration of the cytokine and chemokine milieu. Some words on hepatitis B. We see that in hepatitis B we have two weapons. We have a prophylactic vaccine, where you see on the right side, and we have also treatment. With the treatments of nucleotide analogs, we can control almost all patients. However, in vaccines, we still have a lot to do. We know that birth vaccination is limited in areas like parts of Asia and Africa. This is one example, and the challenge of today is that only 19% of the 47 countries in WHO Africa regions introduced HPV birth vaccination by July 2017. And so hopefully in the future, we will have universal neonatal vaccination against hepatitis B. The hope for the future is that we will also achieve HPV cure. And there is a huge pipeline now available for novel hepatitis B therapies in various stages of clinical development. The real therapeutic challenge now is hepatitis D, Delta, which we call the devil, because only limited therapies are available. We have Delta as co-infection of hepatitis B populations. Here a hotspot in Mongolia, but there are also hotspots in Brazil that I know of, in some cities and villages, in particular of the Amazonian basin. And the progression of liver disease in hepatitis D infected patients is more rapid than in B mono-infected. We have various therapies now available. Interferon for a couple of years now with limited success. We have the prenylation inhibitor lonafarnib, and we have the NAP molecules. Lately, an entry inhibitor for hepatitis B, bulevirtide or Myrclodex, was approved and achieved conditional approval in some region of the world, including the European Union. Some words on hepatitis E. Hepatitis E is a new challenge in our region of the world. We know that hepatitis E is relevant for acute infections in parts of Asia and in the Indian subcontinent. While in Europe, genotype 3 is rather prevalent in the immunocompromised populations and leading there to chronic hepatitis E, also to cirrhosis. We see it in our transplant population, in particular with those with high grade of immunosuppression, like in lung and heart transplants. What we give the patients is off-label ribavirin, however, significant side effects, and there is an unmet need for further treatment options in chronic hepatitis E in the immunocompromised patients. Some words on metabolic liver disease. I will be very limited because there's a whole session in this Congress by leading world experts on metabolic liver disease. And in Europe, you see 20 to 30% of the population, meaning more than 100 million, suffer from NAFLD, and 3% of Nash, which is around 10 million of the population, and also leading to cancer. Some words on nomenclature. There's a huge effort in Europe now by the EASL-Lancet Commission to foresee and look at the present and future state of liver disease. And we think that in particular, using the name NAFLD may be not appropriate. It is further stigmatizing our liver disease patients, and therefore metabolic dysfunction associated fatty liver disease may be the better nomenclature. We all teach our patients that they should change lifestyle. However, despite intensive lifestyle modification, only average weight loss is achieved around 5%. This is the reason why so many medications are being explored in NASH patients. This is just a list, and you will hear more at this Congress. And it certainly in the future will not be monotherapy. It will be combination therapy in Nash or MALFD patients. We also learned that fibrosis remains the main risk factor of mortality in MALFD, and that this mortality is due to cancer. Cancer associated with obesity is a known phenomenon. This is relevant for all kinds of cancer, including and in particular relevant for liver cancer. So in the Western world, it's in particular obesity which is driving liver cancer now, while overall many populations of the world, it's viral hepatitis. Some remarks on liver cancer. What is new in HCC of today? It is less local regional therapy, less than we did before, and more and earlier systemic therapy. Second, immuno-oncology is the new standard and first-line treatment. This here is the latest treatment algorithm of ESMO, published in Annals of Oncology. This is the updated 2020 version published in 2020. Here you see that TACE, which is widely used, at least in Europe, that the assess of response has to be taken earlier. We now, after the second TACE, 6 weeks afterwards, we switch to systemic therapy if there is no response. And the second is that the standard of care recently has changed from sorafenib to a combination of a PD-L1 antibody plus a VEGF antibody. It's atezolizumab and bevacizumab, according to this publication in the New England Journal of Medicine. And this data, the study was updated at ASCO GI 2021, showing that of combination of atezo plus bevacizumab has a superior survival. And there is very interesting, very recent data. And this comes out of Germany. The senior author is Dr. Heichenwälder. And he has shown that HCV therapy of tomorrow may be further personalized. This group has shown that in particular patients with a viral etiology profit from immunotherapy of HCC less than metabolic liver disease, and this may further change the therapy in the future. And then cholangiocarcinoma. Cholangiocarcinoma is increasing. In particular, cholangiocarcinoma intrahepatic. And what's new of cholangiocarcinoma of today is that precision oncology has entered second-line treatment. And here is the list, the map of genomic alterations in cholangiocarcinoma. And the molecular analysis of cholangiocarcinoma have shown us that there are numerous druggable alterations that have been identified, in particular FGFR1-3 fusions. And this is taken out of a phase 2 study with pemigatinib in second line, and it shows a superiority with a median overall survival of 21 months, with this impressing a second line treatment, and therefore second line treatment is standard of care for targeting FGFR2 fusion. In tomorrow, certainly we will also see precision oncology in first line treatment. And this is a paper from Future Oncology, the FIGHT 302, and it's first line pemigatinib versus gemcitabine plus cisplatin, and maybe this regimen is the nail in the coffin of the standard gem-cis first line treatment. So genetic testing is now reality. Only some very few words, only one slide on oncology. I'm well aware that you are dealing with liver toxicity due to alcohol at this meeting, and the UK Commission on Liver Disease and the EASL-Lancet Commission also acknowledges that in particular in Europe, it's the region where alcohol intake is highest, and therefore also alcohol-related liver disease is of highest prevalence. We had to learn that only strong intervention will change the natural course. However, liver disease is not only alcohol, fat, and virus. There are various rare liver diseases, and some of them I will discuss. I want to mention the European Reference Network for Rare Liver Diseases, ERN Rare Liver. This is a network of various countries. Full members are shown here. Unfortunately, we lost the UK due to Brexit, but we have a system in place, a network that aims to improve the standards of care and clinical knowledge in rare liver diseases across Europe. And here there's the EU Clinical Patient Management System that you can present, and physicians can present patient cases, and expert opinion from ERM members are provided. Some remarks on the rare liver diseases, in particular autoimmune. I will not speak on PBC, some remarks on autoimmune hepatitis and PSC. The latest guidelines come from AASLD 2020, and the main message is that first-line treatment in non-cirrhotics is prednisolone or budesonide together with azacitidine. In cirrhotics, no budesonide, prednisolone monotherapy in severe acute. Second line, either MMF or tacrolimus. And third line is experimental. And the experimental third line therapies are TNF, anti-B cell antibodies like rituximab, but also Tregs, IL-2 and IL-2 mutants. And this therapy targets at the knowledge that we gained in recent years on the molecular pathogenesis of autoimmune hepatitis. Finally, some ideas on PSC, which is the black box of hepatology. And I really hope that we will bring light into the black box of hepatology. We know very little about the pathogenesis. It's a miracle, the association of bile duct cancer, PSC, and its high association with inflammatory bowel disease, and treatment is very limited. However, it's very important to make the diagnosis of bile duct cancer before cancer develops. And these are efforts from our group to look at proteomics in bile in Europe. And our group has identified proteomic profiles that identify patients at risk to develop cholangiocarcinoma. The treatment of PSC is either medication, but UDCA is controversial. It has some benefit on prolonging or preventing colonic cancer. It has some benefit also on liver enzymes. It's controversial, in particular in high dose, endoscopy for biliary strictures, and finally liver transplantation. In Scandinavia, PSC is #1 indication for liver transplantation. However, there is interesting movement for the future in new therapeutic approaches. There are targets like the Fxr receptors. There are antibiotics, there are also microbiota transplantation, but very hopeful is NOR-UDCA. There's a positive phase 2 study and a phase 3 study ongoing under the leadership of Dr. Trauner from Vienna, Dr. Ficker from Graz, and myself or other PIs, and hopefully later this year or next year, we will see final results. Very lately, I want to discuss with you drug-induced liver disease. We are aware that most drugs are metabolized in the liver, and when we have elevation of liver enzymes, we also have to question whether there's drug-induced liver disease behind it. And all over the world, drug-induced liver disease has to be taken into our consideration. What I also want to mention at the very end of my talk is that we as specialists, we mainly take care of end-stage liver disease, of end-stage and its complications. However, over 90% of liver disease is preventable. And therefore, there is now time to shift the focus to the prevention and early diagnosis in order to avoid end-stage, which also means that more than until now, we have to involve the primary care physicians to be aware of liver disease and helping us to diagnose early, refer to the specialists early enough. So here I am at the end of my presentation, hepatology, yesterday, today, and tomorrow. And I thank you very much for your attention and for inviting me. Thank you very much.
Thank you very much indeed, Professor Moises, for your brilliant lecture review for many years for all liver disease. And thank you very much indeed, Professor Brandão, that represent our hepatologist in Brazil, because he's a president of Brazilian Hepatology Society. Now it's a great pleasure. I introduce my friend Nathalie Leite. She's a professor in the internal medicine in the University of Federal of Rio de Janeiro, and she's going to share with me. And it's my pleasure to introduce the international speaker. And after Nathalie going to present our colleagues. Michael Mines, Professor Michael Mines, you could stay in our meeting. It's our pleasure to continue to participate for Hepatic Pernambuco Jubilee, Silver Jubilee. The first speaker, international speaker, will be Professor Arun Sanyal. He's a professor of the Center of Clinical and Translation Research and professor in Gastroenterology Division of Department of Internal Medicine in the VCU School of Medicine. The next speaker will be Dr. Mohammed Siddiqui, that he's the same university from Professor Arun Sanyal. He's a professor in the same department. And the last one will be Professor Philip Nilsson, that you will introduce later on. Nathalie, I pass my talk to you to present the Brazilian speakers.
Então, primeira a ser apresentada é a doutora Rosamar Rezende, que vai apresentar o caso clínico. Médica assistente, divisão de gastroenterologia, Hospital das Clínicas, na Faculdade de Medicina de Ribeirão Preto, USP. É médica responsável do ambulatório de hepatite do Centro de Referência em Especialidades de Ribeirão Preto, doutorado também pela Faculdade de Medicina de Ribeirão Preto, USP, e pós-doutorado pela Faculdade de Medicina, USP. Vice-presidente também da APEF, biênio 2021-2022. Posso apresentar todos?
Sim. Sim.
Então, vou apresentar a professora Cláudia Oliveira, a professora associada e coordenadora do programa de pós-graduação do Departamento de Gastroenterologia da Faculdade de Medicina, Universidade de São Paulo. Professor Edson Parisi, professor adjunto da Escola Paulista de Medicina, disciplina de Gastroenterologia Clínica da Escola Paulista de Medicina, Unifesp. E a professora Elma Cotrim, professora titular de Gastroenterologia e Hepatologia, Faculdade de Medicina da Bahia, Universidade Federal da Bahia, líder do grupo de pesquisas em esteatohepatite não alcoólica e membro titular da Academia de Medicina da Bahia, especialista em hepatologia. E, por último, também o apresentador de mais um caso clínico, o Dr. João Marcelo Neto, médico e professor, né, do Serviço de Hepatologia da Universidade Federal do Rio de Janeiro, do Hospital Universitário Clementino Fraga Filho. Um prazer e podemos seguir.
Okay, our first speaker, Professor Arun Sanyal. Nathalie Leite present our Brazilian speakers here, just on the room. And their first lecture will be delivered from Professor Arun Sanyal.
I'd like to thank the organizing committee for this very kind invitation, and I'm delighted to be talking about cardiovascular disease in patients with fatty liver disease. So we as liver doctors often think of fatty liver disease as mainly a liver issue, and our emphasis and focus is that patients, in preventing patients from early disease to getting cirrhosis of the liver. And once they get cirrhosis, then the management changes to management of complications of portal hypertension and then eventually transplantation, depending on how sick they are and decompensated they are. However, if we look at it, that does happen, but there's in competing risk model, what can happen to patients with fatty liver disease is most of them will not get cirrhosis of the liver. They'll die of heart disease, they'll die of cancer-related death, and there's emerging data that sort of underscores the association between fatty liver disease and non-hepatic causes of mortality. And if we look at natural history studies, cardiovascular disease and cancer disease associated mortality are far superior to liver disease alone. So this is the premise for this talk, and this is why it's important for us to understand what is it about liver that predisposes patients to cardiovascular disease, particularly what is specific about fatty liver disease that predisposes them to it. So the first thing is that patients with fatty liver disease are at higher risk for developing cardiometabolic risk factors that can then predispose them to developing cardiovascular events. One such factor is hypertension. And what this slide shows in that individuals with hypertension, the patients with fatty liver disease are at higher risk for developing hypertension. Here we're looking at compared to the lowest versus the highest fraction of patients with fatty liver disease, the risk of hypertension is considerably higher. And this is another study looking at patients who have fatty liver disease. And we can see the prevalence of hypertension in these individuals tends to increase when they have fatty liver disease. And patients with fatty liver disease are about 70% higher risk of developing hypertension. Now, the relationship that I've shown is so far is that patients who have fatty liver disease will go on to develop hypertension. And this is independent of other risk factors such as age, visceral adiposity, gender, smoking history, physical activity, factors that are sort of cardiovascular risk factors. But there's a bidirectional relationship. So patients who have hypertension, who yet do not have fatty liver disease, over time will develop fatty liver disease. So again, this kind of goes hand in hand, the relationship between fatty liver disease and hypertension. And part of the reason why that is because there's a lot of shared pathophysiology that not only predispose patients to hypertension, but also predisposes them to fatty liver disease. So this is just a very cursory review of how this may happen. If there's certain genotypes that have been identified with angiotensin pathways that have been associated, patients, just like renin-angiotensin may predispose patients to developing renal disease. There's some emerging data that suggests that angiotensin may also increase the risk of hepatic fibrosis, particularly in patients, particularly in animal models. Patients who have fatty liver disease, we know that they're increased risk of renal fibrosis, their increased risk of albuminuria, which are risk factors for developing hypertension. Patients may also be at risk for developing diabetes. And in insulin-sensitive states, what happens is insulin causes vasodilation through PI3 kinase and AKT pathway. But as patients develop insulin resistance, MAP kinase tend to cause more vasoconstriction. So there's sympathetic activation that causes vasoconstriction as patients develop diabetes. There's also chronic inflammation, hypoadiponectinemia, which then again causes vasoconstriction, increases the risk of developing hypertension. And as I will show later, patients with fatty liver disease are increased risk for endothelial dysfunction, vascular inflammation, which are known risk factors and mediators of hypertension. And so there's, again, shared physiology and pathology that links patients with fatty liver disease to eventually developing hypertension. In addition to hypertension, we all know that there's a very close association between obesity and NAFLD. And here what we're looking at is prevalence of obesity as prevalence of NAFLD. So we can see as prevalence of obesity increases, so does prevalence of NAFLD. And this has been demonstrated in multiple studies in the bariatric population, in the eastern part of the world. It's been demonstrated in US, Europe, everywhere. So there's a very strong association. And recently we showed that as patients who develop obesity, they tend to have a decline in adiponectin, which is a protective adipokine or adipose tissue specific endocrine factor. And then patients who have this decrease in adiponectin are at much higher risk of cardiovascular events over time. So again, this links cardiovascular disease to obesity to fatty liver disease. Now, fatty liver disease is also a risk factor for developing diabetes, and this is sort of a summary slide for a number of studies that have shown that patients who have fatty liver disease are at higher risk, incident risk of developing diabetes. And if that fatty liver disease gets better, then the risk returns back to baseline. And then as fatty liver disease, and as they have more fatty liver disease, then the risk of developing diabetes goes over time. And not only does presence of fatty liver disease, but also severity of fatty liver disease can increase the risk of developing diabetes. Here, the severity of fatty liver disease was stratified based on non-invasive fibrosis models. So here we're looking at NAFLD fibrosis scores. And as you can see in patients who have no fatty liver disease, presence of higher NAFLD fibrosis score significantly increases the risk of developing fatty liver disease. So again, fatty liver disease tends to promote development of cardiometabolic risk factors, which then can predispose individuals to developing cardiovascular disease over time. This is a slide that shows the relationship between fatty liver disease and lipid. And here this is the CRN data. And you can see as patients with fatty liver disease, the prevalence of hypertriglyceridemia, hyperlipidemia, low HDL is considerably high. And as patients' NASH improves, these changes in lipids tend to get better, suggesting that there is an intrinsic and intimate relationship between lipids and fatty liver disease, which then is a surrogate of cardiovascular disease. So let's try to understand this relationship a little bit better. So why does this happen? Well, this happens because liver is the central organ in lipid homeostasis. And as patients develop fatty liver disease, they tend to make more triglycerides, more cholesterol, as you can see. And then this triglycerides tends to get packaged in VLDL. And in patients with liver disease, these VLDL molecules are big. So they have a lot of triglycerides, so they're triglycerides enriched. And these VLDL molecules then are put into circulation. And in circulation, they are slowly metabolized, much longer than a smaller VLDL molecule. And they tend to turn into these small, dense LDL. Now, small, dense LDL have certain unique properties that predispose, that makes them actually at higher risk for cardiovascular disease. One is that they have low affinity for LDL receptor. And LDL receptor in patients with fatty liver disease is downregulated. So not only is they have a less affinity for LDL receptor, but LDL receptor is downregulated, meaning there's more small dense LDL molecules that are floating around in circulation in our blood vessels in patients with fatty liver disease. And because of their size and their affinity, they're able to go through the endothelial layer and tend to cause fibrofatty plaque formation. They tend to also be readily oxidized and taken up by macrophages and lead to foam cell formation. So they're hypersensitive to oxidative changes and inflammatory changes. And eventually what can happen is the plaque ruptures, and as the plaque ruptures, it leads to a cardiovascular event, complete blockage or occlusion of the coronary arteries, and eventually leading it to cardiovascular event. So this is why liver is so central in atherosclerosis, because liver plays a key role in lipoprotein metabolism. And patients who have fatty liver disease, and this is again, we're just focusing on small dense LDL cholesterol, they tend to have much higher levels of small dense LDL, even when we're accounting for height, weight, BMI, gender, age. And then patients who have, and insulin resistance tends to make these numbers a lot higher, meaning there's a multiplicative effect of insulin on atherogenic dyslipidemia. And then the severity of liver disease tends to also affect what happens to the small dense LDL cholesterol. Whereas patients who have just fatty liver disease will have significant increase in it, but as patients progress to NASH or they have NASH, there's a further increase in small dense LDL. So again, the risk of cardiovascular disease is not only present in fatty liver disease, it tends to increase with the severity and the type of fatty liver disease. This is a slide that shows what is the impact of the small dense LDL cholesterol. And here is what we're looking at: small dense LDL cholesterol. In patients who have low small dense LDL cholesterol, they're actually fairly protected from having cardiovascular events in the future. But if they have high small dense LDL, then the risk is considerably high over time. And again, because small dense LDL is because when we're measuring small dense LDL, we're measuring actually the type of LDL cholesterol that causes problems, we're able to predict this risk far better than if we were to just look at LDL cholesterol. So this sort of starts to get it starts to beg the question is when patients have, what's the best way to risk stratify these patients? Should we be relying on usual parameters like obesity, hypertension, Framingham risk score, LDL, or should we be actually looking to do more better risk stratification with some of these specific lipoprotein parameters? But again, that's sort of a discussion for another day. Now, what happens as patients, as these atherosclerotic lipoproteins tend to accumulate, they cause atherosclerotic disease. So again, what we're looking at is intimal medial thickness of carotid arteries in patients who have fatty liver disease. They tend to have higher compared to control. And then again, there's an association between simple steatosis and NASH, whereas patients with NASH have more carotid artery medial thickness than patients who have fatty liver disease. And this shows calcium channel scoring here. And patients who have fatty liver disease tend to have more than patients who do not have it. And this is a slide that shows what happens to these patients over time. So here we're looking at patients who have fatty liver disease, which is the solid line, and the dotted line are patients without fatty liver disease. So if we follow patients over time, patients with fatty liver disease are much higher risk for disease progression or progression of their atherosclerotic disease burden compared to patients who do not have it. So again, underscoring in longitudinal studies that presence of fatty liver disease does increase the risk of developing atherosclerotic disease. Now, once patients have developed atherosclerotic disease, that's by itself is not enough to have a coronary event. Several things have to happen. First is the anatomy of what a coronary plaque plays a key role in it. So there are several factors that are associated with a fibroplaque that's vulnerable. So it's about it can rupture. One is they have a thin fibrous cap. There's inflammatory cells in this plaque. They have lipid core, and there's plaque hemorrhage. So again, these are, and then there's remodeling. So the endothelial is constantly remodeling, and these are factors that predict a plaque that can potentially rupture over time. And when we look at patients with fatty liver disease compared to patients without fatty liver disease, we notice that they have more plaque remodeling, and they have lipid core plaques, again, that are much higher than patients, control patients. So again, they're forming plaques, but these plaques are unstable. And another predictor of unstable plaque is calcification. So microcalcification is associated with a more unstable plaque, and as plaque tends to mature over time, it tends to lead to stable plaque formation. So in patients with fatty liver disease, what we're seeing is they tend to have more microcalcification, and if they have compared to patients who are controlled. And not only patients have coronary artery disease, and this is a study looking at patients who are presenting with acute coronary syndrome in a hospital setting. Patients who have fatty liver disease, they're actually also more likely to have multi-vessel disease. So they tend to have more diffuse coronary artery disease compared to patients who do not have fatty liver disease. But on top of that, they have poor collateral circulation. So anybody who has ischemia, if they have adequate collateral circulation, they're able to reperfuse that area that's affected by plaque rupture and then vessel occlusion. But patients who have fatty liver disease tend to have worse collateral circulation, meaning that their myocardium is significantly higher risk for sequelae of that myocardial infarction than somebody who does not have fatty liver disease. So they're anatomically, there's changes, but let's look at actually more physiological changes in patients with fatty liver disease. So here we're looking at vasodilation, and this can be either vasodilator that's endothelial dependent or endothelial independent. And in this study, they actually put blood pressure cuff as well as use nitric oxide to cause vasodilation. And what happens under normal circumstances, if there is ischemia, our blood vessels tend to dilate to be able to continue the supply of blood. And in patients who have fatty liver disease, they don't tend to vasodilate. So the amount of blood that's going in, it tends to get limited. And if they have NASH, that degree of limitation is even more. And this is both endothelial dependent and endothelial independent mechanism. So This is another key factor of how patients can actually have cardiovascular events. Now, when somebody is actually having an event, so actively has plaque rupture, comes to the hospital with a myocardial infarction or a heart attack, what happens is the distal arteriole in these coronary blood vessels tends to vasodilate. So they're actually able to maintain pressure. And this is called coronary flow reserve. And when we look at patients who have fatty liver disease, they have significant impairment within their coronary flow. And they have almost a 30% reduction in their coronary flow. So again, all of these suggest that these patients with fatty liver disease are higher risk for developing atherosclerotic disease. They have more extensive disease, and they tend to have diminished compensatory responses such as vasodilation that then predispose them to worse outcomes. And what is these worse outcomes? Well, this is what this is, and this is a composite: coronary events, strokes, peripheral artery disease, and a composite of these events. And as you can see, patients who have fatty liver disease tend to have more of these events, underscoring the relationship between fatty liver disease as well as cardiovascular disease. Now, one thing that I want to point out is that as patients progress to cirrhosis, it may present a very different picture. So here we're looking at same thing, small dense LDL or LDL particle size, and patients who have no fibrosis or advanced fibrosis, they tend to have significantly higher levels. But as they progress to cirrhosis, their numbers get better, their lipid profile gets better, their small dense LDL gets better. And it gets better because they have synthetic hepatic failure, even if they haven't decompensated yet. So this is looking at patients with compensated cirrhosis. And however, if you take these patients and do angiography, patients with NASH, 1 in 5 will actually have coronary artery disease. And more importantly, about 20%, 25% will have multi-vessel disease. So this is important because when we are evaluating these patients for liver transplantation, a normal lipid profile should not stop their coronary cardiovascular assessment. Because if these patients, particularly with multi-vessel or obstructive disease, are not optimized prior to transplant, they can actually have significant coronary complications after transplantation. And part of the reason why it stays out of our mind is because of this, and this is a competing risk model. Patients who have decompensated cirrhosis, their likelihood of a cardiovascular event is so much lower than a risk of liver-related event that we tend to forget about it. And furthermore, you know, these atherogenic lipoproteins tend to go down. So it's the combination of these factors that tend to make us not focus on the heart as patients decompensate. But it's very important because, as I showed you before, their risk of having coronary artery disease is considerably higher. Now, how do we manage this coronary artery disease or cardiovascular risk? Well, the therapy that we have available, which is statin, has excellent data behind it. And again, this is showing from the Greece study that patients who are on statin therapy, there's a 44% improvement in their LDL. There's about a 33% improvement in their triglycerides. Similarly, we see a significant improvement in their total cholesterol. But most importantly, there's almost a 20% absolute risk reduction in cardiovascular mortality. So statin therapy in patients with fatty liver disease saves lives. This is a key point here. But the unfortunate reality is that statin therapy may not be used in our clinical practice. And this is the study out of a VA that shows that almost 90% of patients with fatty liver disease, they qualified for statin therapy, 90% of patients. But statin therapy was only used in about 60% of patients. And once the physician, the primary care physician, realized that patients may have fatty liver disease, statin therapy was discontinued. So our number tends to drop. And it wasn't because that these patients were having complications with statin therapy. Actually, the complications of statin therapy was about 5 to 10%, so really, really low. But the therapy was stopped because there's this thinking that statin therapy is associated with worsening liver function. It can predispose patients to liver injury. While that can happen, it's exceedingly rare. And the 20% absolute risk reduction warrants that we put all of these patients on therapy to improve their overall outcome. Now, we know that there's multiple therapies that are being developed for treatment of NASH because there's no approved therapy. But we have to be mindful of how these therapies are going to affect their cardiovascular risk profile. And this is looking at obeticholic acid. And obeticholic acid tends to cause LDL cholesterol to go up. And here we're seeing sort of a mixed picture on their VLDL particle. And when we look at their LDL particle, we see that obeticholic acid tends to cause an increase in of the more atherogenic small dense LDL particle. And it also tends to cause a decrease in their protective HDL. So this is large HDL quantity. So what's the clinical impact of these changes in lipids with obeticholic acid? We don't know yet. But what's important is that these patients are managed appropriately as they're being put on this therapy. And this is data, a proof of concept study in which patients were put on obeticholic acid, and it caused the increase in LDL cholesterol. But importantly, once they were started on statin therapy, that LDL cholesterol tend to decrease back to below baseline. So this is important because we have to use appropriate therapy not only to treat liver disease, but also address their cardiovascular risk because that's what's going to get them in trouble over time. So to summarize, there's a bidirectional relationship between fatty liver disease and risk of cardiometabolic diseases such as diabetes, dyslipidemia, obesity, which can increase the risk of cardiovascular events in the future. Liver is central to atherogenic risk because it's the key organ involved in lipoprotein metabolism. And this can lead to then development of atherosclerotic disease. Once these patients develop atherosclerotic disease, there's also concurrent compensatory vascular adaptation to ischemia that are impaired in patients with fatty liver disease. So they're not able to respond as well when they actually do have a cardiovascular event, and they're more likely to suffer a sequelae of their cardiovascular events. Statins tend to improve cardiovascular outcomes in patients with fatty liver disease, but unfortunately they're underutilized despite being safe in patients with chronic liver disease and even decompensated cirrhosis. And finally, the impact of emerging therapy on cardiovascular disease in patients with fatty liver disease needs to be better defined. Thank you for your time.
Thank you very much indeed, Dr. Mohammed Shadab. Can you do me a favor, please? Can you double check with Arun because he's not in the room and he sent me a message, say that we are delayed, but he's not on the room so far.
Então, quem vai apresentar é a doutora Rosamar Rezende, né? Como eu havia já apresentado, é médica assistente, divisão de gastroenterologia do Hospital das Clínicas da Faculdade de Medicina de Ribeirão Preto, USP. Pode prosseguir, Rosamar, por favor.
Olá, boa tarde a todos. Good afternoon. Congratulations, Leila, on the 25 years of this important Congress. Thank you for inviting me. It's a pleasure to be here. Okay, I have 7 minutes to present a clinical case about NAFLD or MELHOR and CV risk. This is a clinical case that has been followed by Dr. Liliana Mendes for a long time. Thank you, Liliana, to send this case to me. This is a male patient. When he started the treatment, he was 32 years old. He came with steatosis and increased liver enzymes. He has hypertension, no history of alcohol and drugs use. He is sedentary, no history of family CVD. In his clinical exam, he is overweight. At the beginning, the exams show elevated liver enzymes and iron overload. He discovered a genetic condition. He has hemochromatosis, but he started very early the treatment with fleburonide. During the follow-up, he developed insulin resistance, but now he has a diabetes and dyslipidemia. After 3 years of the follow-up, he had a liver biopsy done because he with the elevated enzymes, continue with elevated enzyme. The histology shows he has steatohepatitis and advanced fibrosis. The PASSO is 0. Now the FibroScan shows he has cirrhosis with portal hypertension, he has small varices and severe steatosis measured by CAP and PDFF. And the MRI shows a light ion quantification. And what about the cardiovascular assessment? This patient has many exams. The majority is normal, but he has IMT, light IMT of clarity, but not plaques. Sorry. And the blood pressure is not completely normal. When you see the cardiovascular risk in the timeline, when this patient started the follow-up, he had a low risk by frame score, and now he is 48 years old. He has many comorbidities like obesity, hypertension, diabetes, and lipidemia. And now the risk of CVD is intermediate. But recently he had a calcium score, it is high, and he went from intermediate risk to high risk. I think the major problem with these patients that is he hasn't changed his lifestyle. He doesn't practice exercise and he has unhealthy diet. And now he's used a lot of medication to control the blood pressure, the glucose, and the cholesterol. And the target of LDL now is less 70 because he has high risk of CVD. And what about the guideline recommendations for primary prevention of CVD? The guidelines give special attention for diabetes. Recently, ESC recommended a new classification of CVD risk in diabetes. There are something is very important like diabetes duration, but the American Heart Association continues ASCVD risk, and depending the risk, there are a new lipid targets and glucose lowering treatment. I don't have time to explain all the recommendations, but I recommend read this guideline on the websites. But the question is, what about NAFLD? Then I have some questions for discussion. First, which score for risk prediction of CVD is more appropriate to use in NAFLD? How far to go with cardiovascular exams in asymptomatic patients with NAFLD? Is there any impact of the new concept MELHOR in relation to cardiovascular disease? And the end, should you include the risk of cardiovascular disease in addition jury for choice of the drug treatment for NAFLD or MELHOR, or currently and the future option around the study? That is all. Thank you for your attention.
Who wants first? But it could be Claudia. Do you want to answer the first of the questions Rosamar has asked us?
Thank you so much, Nathalie. Congratulations, Leila, for the meeting. 20 years for this meeting. It's very, very nice of your work. Thank you. I would like to transfer the questions, Nathalie, to Siddiq, because Siddiq is very smart about the cardiovascular risk. And Siddiq, in your clinical practice, what do you do, such as this patient, a young patient that has 15 years of NAFLD disease, asymptomatic? What do you do in VCU about this type of this patient? Because we have some doubts if you do cardiovascular evaluation under 40 years. How do you conduct this?
Yeah, so that's a very good question, Claudia. And, you know, one thing that we have to sort of understand is, you know, patients tend to get atherosclerosis early on. And, you know, the problem is sometimes by the time they have a first event, it may be too late because, you know, for some, when they have a MI, that could be that they could die from this. Other people, when they have a clinically apparent MI or cardiovascular event, they may develop ischemic cardiomyopathy. So again, all of these things tend to affect what happens downstream. You know, patients may get cirrhosis of the liver and they may have multi-vessel disease that we cannot do anything about. So they may not be transplant candidates. So whenever I approach these patients, I'm thinking about not only how do I manage this risk right now, but what do I do to actually reduce the risk of something bad happening to the patient in 5 years, 10 years, 20 years, 30 years. And you know, from cardiac literature, we know that if we intervene early, we can make a huge impact, right? So the idea is to let the patient know that they are at risk, and they have to do all of the things that, unlike as you were presenting, the patient gained weight, they got diabetes, they didn't do all of that, they weren't active. So you know, medicines don't always fix the problem, and the patient has to participate in it. So exercise, eating better, all those things have a huge impact because there's studies that show something as simple as exercising a few times a week reduces the risk of cardiovascular events. So, you know, that doesn't require any cost. There's no money, there's no medications, nothing. So that's something like that, they have to understand that they have to do. The second thing is when I have somebody who's actually needs lipids, I tend to start them on statin therapy early on and tend to titrate their medications accordingly. One of the things that we don't understand well is what are targets in patients with concurrent cardiovascular disease and fatty liver disease, because most of the data comes from non-fatty liver disease patients. There's a number of emerging data in cardiac literature of trying to risk stratify these patients better. But how we do that, how does therapy affect that cardiovascular risk assessment is not known. So in my practice, and according to most of the guidelines, once I know that they need statin therapy, I try to intensify statin therapy until, you know, their LDL is at goal, or that's the maximum tolerated dose that they can tolerate.
Thank you very much.
My pleasure.
Natalie, there is one question for
Q&A. Yeah, there is one question. Can I ask the question?
Yes, please. Ask
Professor Siddiq, do you use VAI, Visceral Adiposity Index, to evaluate the CV risk in lean NASH? Is it validated?
So that's a good question. And again, so visceral adiposity index is more of a marker of liver fat than it is of NASH. So to establish the diagnosis of NASH, you need a biopsy, first of all. And the thing is, all of these, and including the cardiovascular risk models, they're not as well validated in patients with fatty liver disease. Mm-hmm. So basing all my clinical decision-making on those models is less optimal. So again, using the more established models, like as presented, the ASVD score, looking at the Framingham risk score, those things are much better, looking at their lipids, looking at their comorbidities, and then, you know, treating the patient.
Leila, Natalie, can I?
Yes, of course.
Leila, please.
Primeiro, eu queria agradecer muito, acho que vou falar em português inicialmente, agradecer a Leila, é um privilégio participar do Jubileu de Prata, do workshop de Pernambuco. Talvez eu tenha participado de mais de 80% dos eventos, pela amizade que nós temos. Então, eu acho que você tem que estar muito orgulhosa do seu evento de 25 anos ininterruptos. Então, parabéns mais uma vez. So, I would like to ask something for Dr. Mohamed. Let me see. Thank you very much for your talk, very nice. But I would like to get back to discussion of statin NASH, because this is a great interest for us clinics and hepatologists about that. My question is, do you recommend statin for all patients with NAFLD, including patients with steatosis or steatohepatitis, independent of dyslipidemia, or only for patients with dyslipidemia? Because there are some evidence that statin can help patients to improve enzymes, like you show here, and maybe can improve also histology in this patient. How is your opinion? What would you recommend? When you recommend it?
So I think that's a very good question and a very important question. And I think, you know, and you're sort of getting to the point where should we use statins to treat their cardiovascular risk alone, or should we use statins to treat the combination of liver as well as the heart? And I think while there is some data that it affects liver enzymes, there's some data that it may affect, there's no conclusive data yet that it's going to make the histology better, it's going to have fibrosis regression and things like that. So the predominant use for statins in this patient population is for treatment of cardiovascular risk. With regards to the liver disease, there's emerging data that in patients with more advanced fibrosis and cirrhosis, there may be a benefit of using statin therapy. But I think that before recommending its widespread use, I think we have to wait for some of that data to mature before we can say that we can use it in this patient population. But you're absolutely right. There is some emerging data showing that statins are maybe useful in more advanced liver disease and cirrhosis.
In this case, you have two conditions. You have hemochromatosis and Nash. Maybe it's hard to treat this patient.
No. I mean, I think statins are really well tolerated, so I think it should be okay. We actually, at our institution, we did a study where we looked at patients with high MEL scores. So we're talking about MELs of 20 plus, and while they were waiting for transplant, in whom we had documented coronary artery disease and multivessel disease. And use of statin therapy in those patients was not associated with worse liver outcomes. And the need to discontinue statin therapy was exceedingly small. So even in the sickest of sick liver patients, you can use statin therapy safely.
Nathalie, tem outra pergunta aqui. There is another question. I'd like to say that we now is the webinar Hepato Pernambuco sent to me. That's 1,860 participants in the meeting. But we only until maximum 20 to 250 in the room because a lot of questions could be coming on. But I'm sure that I trying to respond all the questions so for the orders. Nathalie, can you ask another question for the speakers?
Yes.
Professor Philip Nielsen, if you could participate for this round case, is a pleasure twice as well, and Professor Paris so far. Professor is there any target to LDL to achieve with statin therapy?
Okay. Yeah, so the lower the better, and it depends on comorbidity. So intensifying statin therapy in these patients to the maximally tolerated doses is what would have the optimal risk reduction. But statins have a lot of pleiotropic effects. So use of statin therapy in these patients, while the lower the LDL, the better, but even putting them on it would help.
Do you measure lipoprotein A or small dense LDL in your clinical practice?
So we actually do measure lipoproteins in our clinical practice here. And it's through mainly from a research clinic perspective where we actually use that to risk stratify them better. But that's not something, at least in the US, that can be done on a wide scale level, partly because insurance company does not pay for lipoproteins. And lipoprotein costs can cost a lot of money. So that's why widespread use in US is difficult clinically, but in our research clinic, we absolutely do use them. And the biggest association with cardiovascular events was actually small dense LDL in our cohort. Apolipoprotein A, did not pan out as a predictor, but the number of events was smaller. as well as the cohort was relatively smaller. So that doesn't mean that there's no association. The cohort and the sample size and the number of events may have precluded us from measuring those events. So that's all.
Professor Philip, any question? Professor?
Yeah, no, so, I mean, thank you. Yeah, question, Mohammed. So to what extent do you believe that NAFLD is an independent cardiovascular risk factor, or is it just a consequence of the confounding factors that are associated and drive NAFLD?
So I think that's a very good question. And I remember reading a paper by Jerry Reven back in the 1980s. Not when I was in the 1980s. I couldn't read that well back then, but when he wrote it in the 1980s. And he said, and he was talking about diabetes, which I think can be applied to fatty liver disease. A lot of times when we sort of use multivariate modeling and statistical approaches to this, there's so much collinearity that although there may be a statistical association, it's hard to tweak out that biological association. So I think a number of these conditions kind of run together biologically and physiologically. So it's hard to say what's exactly what, but because they run together, I think there's a lot of shared physiology and pathology.
And I think that there's also a nice systematic review of meta-analysis that's come out of Glasgow by Naveed Sattar that was in the BMJ, which I think makes the point that you've just made, which is that they weren't able to identify it as an independent risk factor, but for the reasons you've described.
Siddiq, do you know about some or any drug that acts in endothelial dysfunction? Because it's very interesting, the data that you showed about that NAFLD is different from Nash in vasodilatation. Do you know something new to add in these patients to improve vasodilatation or endothelial dysfunction?
Yeah, so that's a great question. And again, while there's studies that show vascular, there's endothelial dysfunction, there's vascular inflammation, things of that nature, it's hard to actually target these things directly because these may be downstream effects of other things that are going on. There is data with statins that it actually improves some of these parameters. To what extent, again, that needs to be flushed out more in larger cohorts, but there is data showing that statins may affect it. And you published, I think, on this, Claudia, in transplant patient population. So
yes, I and Mario raised.
Can I ask another question?
Absolutely.
Ian, which is the optimal mean of risk stratifying and reducing cardiovascular risk in your clinical practice? Which methods do we choose? So,
we use a combination of looking at Framingham risk or ASCVD risk scores to optimize and risk stratify them. Because we have access to lipoproteins as well, we tend to use that as well. So for instance, if we have a younger patient whose risk score FRS may be low, but their small dense LDL is 42, we'll still start them on therapy because there is some data from Framingham risk cohorts looking at these lipoproteins that it may be a better predictor than looking at either the risk score or looking at LDL, for instance.
I have a practical question. When do you recommend patients for the cardiologists? Patients with NASH?
Yeah, so I mean, I think most of the time we don't necessarily refer them, and this is more sort of the way our practice is set up. We tend to manage the lipid abnormalities ourselves, but if they have heart failure, if they have heart failure with preserved ejection fraction or depressed ejection fraction, we'll send them to cardiology. If they have coronary artery disease, we would send them to cardiology. But as far as just lipid abnormalities, in the absence of any known coronary artery disease, we tend to manage ourselves.
And could you, Mohammed, one question, please. In your practice, what do you use the stratification for risk? You use the ASCVD or Framingham or another risk calculated?
Yes, so we use actually ASCVD risk score or the Framingham risk scores. there is some data with them in fatty liver disease.
Natalie, I think it's better I move to Professor Arun Sanyal sent his lecture, but I'm still waiting for him. He's in another meeting, but I think I could move on to Professor Philip. First of all, it's my pleasure, Professor Philip, to have you in the first time in Hepatologia Pernambuco 2021. I heard it for the early morning from Professor Heaton from King's College that London is sunshiny today. I'm very happy to hear from that. That is, London is a blue sky like in the Recife. That's really nice weather. And it's our great pleasure to have you here in our meeting. And you're going to presentation, your talk now. Professor Philip Nilsson is a professor in hepatology and director of Central Liver in the Research. It's a pleasure to have you here. He's from the University of Birmingham.
Great. Well, thank you very much for the invitation to speak today. And again, congratulations on reaching your 25th anniversary. So you've asked me to speak today on when and how to treat patients with NASH, and Mohammed's very nicely set the background for this. So this slide here, I think, illustrates the spectrum of NAFLD and NASH, capturing both the inflammatory entity and also the degree of fibrosis. And what you'll see is that the two sort of run along slightly in parallel, with fibrosis occurring a little bit later on. And you'll see here that in the bottom, we tend to call advanced fibrosis when people have reached bridging fibrosis, or F3, looking at the Nash CRN grading system. So your first question is, when should we treat patients with NASH? And I think when it comes to, when we're treating patients for NASH, I'm taking that very much as when we're focusing on treating the liver-related elements, because of course we know that cardiovascular risk is significantly increased in patients with NASH, and this meta-analysis really just captures the increased risk on the left of all-cause mortality, which is principally vascular risk, but also some non-liver related cancer. And you'll see there that the risk increases quite significantly with advancing fibrosis. But what you'll notice if you look to the right is that whilst the risk of liver disease also increases with advanced fibrosis, the levels are much lower. So liver disease is a smaller cause of death, although of course that becomes more profound as you develop F3 and then F4 cirrhosis. So I think it's really these data which I think tell me that the focus when it comes to treating the liver disease, so not the vascular disease, but treating the liver disease, is in those individuals who developed advanced fibrosis. Now there's some discussion whether that should be F2 or F3, but I think when it comes to the approval of drugs in due course, I think they'll probably be reserved for people with F3 in the first instance. So the question then is, how do we treat patients? So I think you've heard all around that the management of the metabolic syndrome, and clearly that's really important. Also managing weight, that's difficult to do, and I'll touch a little bit on that in the presentation today, which is a combination of changes in lifestyle as well as weight loss medications. Now there are no licensed medications for NAFLD. There are two therapies which are recommended by many of the liver societies, and that's vitamin E and pioglitazone. But if I touch first of all on the study on weight loss, this is a Cuban study that came out a few years ago, and it was a study that had three components. There was a calorie reduction, there was exercise, and also behavioral sessions. So it was three things that they did. And what you can see is that even in a clinical study in Cuba, only a third of patients were able to lose more than 5% of their weight. So it tells you how difficult it is to achieve weight loss, let alone sustain it. What you can see in the data is that by and large, the more weight you lose, the greater the benefits on liver histology. So you can see here on the left that those people that had resolution of NASH at their second biopsy a year later had lost more weight. But you'll notice that some people lost 15% of their body weight and still didn't have resolution of NASH. So weight loss is good, but it doesn't always work. And then the data on the right are the ones that have been shown quite a lot, demonstrating that as you lose more than 7% or more than 10%, you start to see a significant improvement in liver fibrosis. Now, I think the caution here is that the numbers in the bars on the right are quite small. Not very many patients had advanced fibrosis, so one needs to take it with a pinch of salt before assuming it will always apply to every patient. The PIVNS trial had previously shown vitamin E was effective. Pioglitazone had not been demonstrated to be effective, although other studies and meta-analyses had shown that pioglitazone was effective in non-diabetic patients. These are some more recent data from Ken Kusi looking at pioglitazone in patients with diabetes, and what you can see there is that there was a histological improvement, so a 2-point reduction in the NAFLD activity score that was achieved in 58% of patients versus 17% in placebo. And then if you look at some of the other more common histological endpoints, you'll see that just over half the patients had resolution of Nash compared to just under 20% in the placebo arm. So I think it's fair to say that the histological data for pioglitazone are convincing. I'll talk a little bit around some of the side effects in due course. Another more recent study looks at vitamin E, and this is a study from Nagachalazani and his group, and they looked in a retrospective single center study of people with advanced fibrosis treated with vitamin E or standard medical care, and these data were quite interesting. They demonstrated that transplant-free survival was enhanced in people receiving vitamin E, and the likelihood of developing liver decompensation was also reduced. So really quite, I say provocative because the magnitude of the effect is quite impressive, but it's not a randomized controlled trial, but provides food for thought. So as I said, these are both recommended by EASL and AASLD. There are some considerations though here. You can see with vitamin E, there is a potential increase in hemorrhagic stroke, an increased risk of prostatic cancer, and some suggestions of an increase in all-cause mortality. If you look at pioglitazone, we know about the gain in weight, about 2 to 3 kilograms for most patients. There is a risk of osteoporosis, and there's some concern around bladder cancer risk. So I think the answer is that these can be used. I think it should be reserved in patients who've got histologically confirmed NASH, and there really does need to be a careful consideration in each patient of the risk-benefit ratio. Now, the good news is there's been an explosion really of therapies for NAFLD that are being trialed. So I'm going to go through some of these. This is lanifibranor. So in comparison to, say, pioglitazone or elafibranor, what you can see here is that lanifibranor has an effect on people alpha, delta, and gamma. And we know that if you have the potential action at all three of the receptors, you may be able to tackle the metabolic problems, the inflammatory problems, and also fibrosis in NASH. So you can see here is quite a short study. It's a 6-month study, biopsy before and after. And the primary endpoint was met, and these data were presented at AASLD last year. And what you can see is approximately half the patients receiving the higher dose of lanifibranor met the histological endpoint, which was a composite looking at inflammation steatosis. If you look at some of the other endpoints which you'd be familiar with, NASH resolution, again 45% met that. And what was really interesting was about 40% of them had improvement in liver fibrosis. So really interesting. So this data will hopefully come out in press soon, and there will be a phase 3 clinical trial that comes after that. The other one I wanted to talk about was these are data that Steve Harrison presented looking at FGF19. What you can see here is the aldafermin is the agent. So this is, again, a 6-month study looking at 1 milligram dose. The primary endpoint was improvement in liver fat content. And what you can see here is that there was quite a marked reduction in liver fat in patients receiving aldafermin. So it met its primary endpoint. As part of the study, they also looked in a subgroup of patients at liver histology. And what you can see here is, improvements in fibrosis improvement. So they're about just under 40%, and approximately a quarter of patients had improvement in NASH. So really, intriguing data suggesting an improvement in fat, inflammation, and perhaps also fibrosis. So now I want to come on to GLP-1s, and I think this is particularly relevant given Mohammed's talk. So this is a class of drugs which is already licensed for the management of type 2 diabetes and also has an obesity indication. So clearly improving those things, improving obesity, may well be advantageous to patients with NAFLD, but you can also see here on the right, there's a number of other effects on the liver, which may also be useful. This improvement in hepatic insulin sensitivity, improvement in liver inflammation, which may perhaps provide an additional benefit. So this is the Nash study, which was presented at AASLD and published in the New England Journal. This was a conventional phase 2b trial looking at different doses of semaglutide treated for up to 72 weeks. Patients had a biopsy at the beginning and then a biopsy at the end. The primary endpoint was the conventional primary endpoint of resolution of Nash with no worsening in liver fibrosis. So the results are presented here. And what you can see is approximately 60% of patients receiving the highest dose of semaglutide achieved resolution of Nash versus just 17% in placebo, and that was highly significant. There was, however, no improvement in liver fibrosis as per the confirmatory secondary endpoint, although one of the pre-specified analyses was change in fibrosis stage. So what you can see here, if you look at the orange, which is worsening in fibrosis, you can see approximately 1 in 5 patients on placebo had worsening over that 72-week period, whereas as you increase the dose of the semaglutide, that proportion markedly reduced. So with the highest dose of semaglutide, you can see down to 5%. And there was also improvements in non-invasive markers, suggesting there may well be a positive signal as regards liver fibrosis with semaglutide. So some of the other agents I wanted to highlight, one is Pegulated Fgf21. So we know that Fgf21 is a key regulator of energy metabolism. Unfortunately, endogenous Fgf21 has a very short half-life, approximately 1 to 2 hours. So it's been modified here. And we know that this drug can improve serum adiponectin levels, as well as improve insulin sensitivity. And the paper in the Lancet, as published by Arun, Sanyal a few years ago, again demonstrated quite marked improvements in hepatic fat, as indicated in the top and the middle. Another agent which looks particularly interesting is resmetirom, which is a thyroid hormone receptor beta agonist. We know that this particular receptor is highly expressed in hepatocytes. It's important in energy metabolism in the liver. It also promotes liver regeneration. It also has a beneficial effect on serum triglycerides and cholesterol, as well as improving insulin sensitivity. And there's also a feeling that it can improve mitochondrial beta oxidation of fatty acids and also normalizing mitochondrial function. So what you can see with this particular agent, resmetirom, is that it's a liver-directed, orally active agonist of this receptor, and it has a much greater affinity for the beta receptor as for the alpha receptor. And what you can see here is a really quite a marked reduction, so really quite striking reductions in liver fat, so a 50% relative reduction. And with this particular agent, there's also some histology. Again, what the orange bars demonstrate are rates of Nash resolution, which again, are reasonably impressive, up to about 40%. There wasn't any changes in liver fibrosis in those studies, but we look forward to the phase 3 clinical trial. So finally, I'd like to come on to the Fxr agonists. So there's a multiple modes of action for this class of drugs. It can have an effect on inflammation, perhaps also insulin sensitivity, as well as critically perhaps an effect on stellate cell activation. So this drug went through phase 2 through the Nash CRN and then is halfway through its phase 3 clinical trial. The phase 3 clinical trials often have an interim endpoint at about a year, year and a half, which is histological, and then the longer term endpoint, which is an improvement in hard clinical endpoints such as survival, or development of liver cirrhosis. So obeticholic acid is the agent in question. So the trial has 2 doses here. You'll notice just the huge number of patients needed, so just 2,500. The data presented by Zobe Yonossi at the ILC 2 years ago and published in the Lancet, and again demonstrated a significant improvement in liver fibrosis. So just under a quarter of patients achieved that versus around 10% in placebo. And notably, there was no histological improvement in Nash resolution. There is a question mark around itch. We know that there was an increase in itch in patients receiving OCA. And Mohammed already talked about the lipid profile. I suppose the counterpoint with the lipid profile is that very many of these patients will then end up on a statin. So that may offset the action, but that's something we can perhaps pick up in the discussion. So last slide, really, in terms of treatment paradigms, I think the focus will be on patients with bridging fibrosis and cirrhosis. I think the treatment will need to be long-term. I think that, environmental change, lifestyle change are going to be very important. I think the backbone of drugs will be drugs that impact on weight loss or insulin sensitivity, and then we'll start to add on single pathway modulators, perhaps in combination, to try and achieve further histological benefit. Now, the one caveat to the kind of longer term therapy is as we start to get really effective antifibrotic therapies, you can envisage how you have long-term therapy with the drugs on the left, and then pulses of antifibrotics to try and remodel people from F4 to F3 or from F3 to F2. But it's really exciting times, lots of drugs in the pipeline, so hopefully a brighter future for our patients. So that's all my slides. Thank you very much for your attention. I look forward to questions.
Thank you very much, Philip, for your presentations. Wonderful. I think, Natalie, you're going to start to the case presentation, and Sanyal finish the section later on. Okay? You introduce the Dr. John Marcelo presentation.
Okay. I'm going to introduce Dr. João Marcelo, who is the teacher and works in a hepatology in the Federal University of Rio de Janeiro. He's going to present the next case. Thanks.
He's from Fernando de Noronha, where exactly when our meeting should be held today, but it's pandemic COVID, you have to do online, but he's represents Fernando de Noronha Island, directly from there. João Marcelo presentation the case. Carry on.
Thank you very much. I'd like first to thank Leila for this invitation for the Silver Jubilee. It's a great honor to be here. And I'd like to present a case. It's a 6-7 years old female. She has a previous history of dyslipidemia and osteopenia. And during regular exams, checkup exams, she did a diagnosis of cirrhosis and portal hypertension. On her first appointment, the physical exam shows a normal blood pressure, has weight is 75 kilograms, and the height is 168 meters. The BMI is 26, and the waist circumference is 89. Next, please. As you can see on the photo, she doesn't have any signs of cirrhosis and portal hypertension. She has no sarcopenia, and she is a pretty healthy woman. We performed lab work for her. Next, please. And on the lab work, we looked for liver disease that could be the cause of the cirrhosis. So she's negative for Hep B and Hep C. Ferritin and ceruloplasmin are normal, both normal. She has no autoantibodies for autoimmune hepatitis. The antimitochondrial is normal, and alpha-1 antitrypsin is also normal. On the rest of the lab work, she has a good glucose profile, a slightly high cholesterol profile, with the normal SDUR, creatinine, C-reactive protein, and HOMA-IR. So it's a good lab. We performed an abdominal ultrasound that shows signs of cirrhosis and portal hypertension. We also performed a liver elastography. The FibroScan has a result of 20 kilopascal, and the CAP's pretty high, 320 decibels per meter. We also performed a 2D share wave that shows also high values, 22 kilopascals. And we did spleen elastography with a very high values, 65 kilopascals, compatible with the portal hypertension. We performed an upper endoscopy, and she has 3 small varices. Next, please. So, as she isn't the typical metabolic patient, we decided to perform a liver biopsy just to investigate the diagnosis and the etiology. And the liver biopsy shows evidences of cirrhosis and some signs of NAFLD. So the case summary is a 67-year-old female. She has the confirmed diagnosis of cirrhosis and portal hypertension. And when we look for criteria for MALFD, she has overweight, she has a high waist circumference and high triglycerides, but she has no diabetes. So the questions I would like to propose are, would you guys have performed the liver biopsy on this case? Was it really necessary? I'd like to hear from you, how do you recommend physical exercises on your daily practice? So how do you say to the patient, to the patients, how to do physical exercise? Do you have any evidence to prefer any kind of diet? So do you prefer Mediterranean diet? How do you teach your patients to behave? And last but not less important, how to manage pharmacological treatment for this case? What are the best drug options in 2021? How to monitor the treatment response, and for how long maintain the pharmacological treatment? So that are the questions. Thank you very much.
So, I mean, I guess in terms of the biopsy, I mean, I think my take on the liver biopsy is, you perform a liver biopsy if it's going to change what you do or change what you offer the patient. So, firstly, if there's uncertainty about the stage of disease, then, there is value in a biopsy, because if it shows cirrhosis, you would change the way you manage them. And I think one of the mistakes I commonly see is that people will take a FibroScan of, say, 18, 19, 20, and they will assume they're cirrhotic and manage them accordingly. And yet we know that if you biopsy people with FibroScans of 16, 17, 18, on many occasions they maybe don't have cirrhosis. So in that sense, I think it's a useful confirmatory one, because it changes what you do. If somebody's got a FibroScan of 20, 30, then it's quite likely that they've got cirrhosis. So does knowing the cause of the cirrhosis? Well, I mean, you can probably assume it from the non-invasive test, so that probably wouldn't be a driver. The other reason for considering a biopsy would be for clinical trials. So, there's a large number of trials which, as you know, require biopsy at the beginning, at the end. So that would be how I go about it. But I think that the key point is, A, is it going to change what you do? And obviously, B, it's having that discussion with the patient to see, if they agree. I mean, if they're not interested in a trial, for example, then a biopsy may be of less value. But I don't know what, I don't know if Mohammed's still with us. I don't know how he would practice in the US on this.
So I completely agree. We don't generally reserve biopsy for situations where it's going to clinically change management. And in this case, entrance into clinical trial would be the main driver for biopsy of this patient. There's signs of portal hypertension with presence of varices. So really, I don't think it's going to change management in our case, doing a biopsy.
I have a question, Nathalie, for both Siddiq and Philippe. This patient is non-diabetic patient. And so if you use pioglitazone in this patient, I use in some patients that has biopsy, pioglitazone if fibrosis, significant fibrosis, F2 or F3. But in this patient, the patient is non-diabetic. Do you use pioglitazone without liver biopsy in this patient or not?
So will I start on this one? So So pioglitazone is not a licensed drug for NAFLD, okay? It's recommended in people that have biopsy proven Nash. And that's with all the riders and caveats that I mentioned. So if a patient has cirrhosis, I would not be putting them on pioglitazone because that goes beyond the data that we have. I'll be honest with you, I don't use a lot of pioglitazone, partly because it hasn't passed the evidence barrier that we're expecting of phase 3 drugs. And the other one is that when I discuss it with patients, I get a very mixed response in terms of the side effect profile. Now, I appreciate that from a cost perspective, it's very cheap, and that's something which has to be taken into account. But I wouldn't pushing it. What about you, Mohammed?
Yeah, I agree. I think aside from Florida, there's not a lot of appetite for starting pioglitazone in the U.S. So we're all a little hesitant, particularly when we sort of take into account potential side effects in the patient population.
There is one question for the audience here. I think it should be for you, Mohammed. It's from Cristiane Vilela. Do you think elastography would have any role in the CV risk stratification of NAFLD?
No, so there's no role for fibrosis staging necessarily for risk stratification from a cardiovascular perspective, because there's just no data where it's showing that if we incorporate the severity of disease into any of these models, that it's going to change how we manage these patients. So I think there's multiple studies that have shown these association and independence association, but I think really we just don't have the data to incorporate it widely in clinical practice.
And for you, Philip, in the UK, any elastography role in a CV cardiovascular risk?
As in, what is the role of elastography in terms of cardiovascular risk stratification?
Yes, it's
yeah. I don't think of elastography in that way. I mean, I used elastography as a triaging tool in the main. So in other words, when I'm seeing a patient for the first time, I'll use the FibroScan principally for its negative predictive value. And if it's elevated, then you start to get into the situation where you're considering, the benefits of a biopsy. But I don't really think of it as a CV. So, I mean, of course, patients with NAFLD and advanced fibrosis have increased vascular risk because, they are enriched for the metabolic syndrome. So, but I wouldn't use elastography to drive CV stratification.
I would like to ask a question about lean patient. I have a lean patient, young people, 26 years old, with Nash in fibrosis stage 2, without insulin resistance. How do you approach in this patient? Do you recommend lifestyle modification, or you introduce some drugs for him?
Well, so I'll come. I mean, there are no licensed drugs, so I wouldn't have much there. So I think with lean NASH, to me, there's two things. There's people that have got what I call sort of false lean NASH. In other words, people are reading off the body mass index and rather than making appropriate ethnic adjustments. And also, where the fat is, body mass index is an easy but imperfect tool. So if somebody's got, fat around their waist, visceral fat, then to me, that's moving away from lean NAFLD and moving into just a different variant of normal NAFLD. And then you've got the people that are truly lean, which I think is much, much rarer. I think therefore I would treat those two differently. For people who've got visceral fat, I think you're managing the same things. In other words, you're wanting to reduce body fat and increase lean body mass. Whereas for those people that have, not got that, then I think then you're waiting really for therapies that will help with, hepatic insulin sensitivity perhaps, or inflammation. But we don't have those at present. What about you, Mohammed?
I think I completely agree. I think it's a tough population to sort of treat. And, generally the data with lean NASH is this visceral adiposity. And once you've excluded that, and if they truly have significant NASH and they truly are lean, young, I think oftentimes I'd like to think outside the box. So I mean, thinking that could there be other causes of what we're seeing in histology? So celiac disease comes, for instance. So they may need more workup than just the fatty liver disease that we just because we're seeing it in histology. Just to sort of think outside the box.
Paris could be talking about treatment in Brazil.
Well, first of all, I want to congratulate Leila for this 25 years of continuous liver education in Brazil. It has helped a lot of people. Let me do some comments. First of all, about pioglitazone. We see that in general, 50% of the patients treated with pioglitazone with Nash, they have regression of Nash. And we have learned that the regression of Nash is essential for regression of fibrosis. And the first question I want to ask you, why don't we see such kind of regression in patients if at least half of them have Nash regression? The second question I want to make, Professor Philip, you start treating patients only with advanced fibrosis. But we have some meta-analysis, some studies that shows that even patients with F2 fibrosis, they start to increase the risk for cardiovascular disease and also the risk for dying for liver disease. And why don't you think that F2 patients should not be treated with pharmacological drugs?
Yeah, I'll take the second question first. Thank you. So remember that the time to progress from a liver perspective, from F2 to F3 to F4, is going to be something between 10 and 20 years minimum. So, you can always catch a patient when they're F3 and treat them. I think if you're trying to prevent vascular complications, well, you can do that anyway. The principal way to reduce vascular complications is, managing their lipid profile, their blood pressure, their dysglycemia. At the moment, we don't have any robust evidence that suggests that liver-specific therapies will have a marked effect on the vascular risk. But that's an interesting hypothesis, but we don't know for sure. And then the third reason, it simply is money, is cost. I think that, if you're looking at some of the new medications that come through, the cost effectiveness, if you have to treat a patient with F2 NASH for 20 years to prevent them progressing to cirrhosis, it becomes a very expensive therapy. Sorry, I can't remember your first question. Would you mind repeating it, please?
Paris.
Could you repeat the first question, please?
Paris.
Sure. The first question was, why not F2? The second is, we have learned that people to regress fibrosis, they have to have regression of Nash. Pioglitazone, 50% of the patients has Nash regression. Why don't you see so many patients with fibrosis regressions? In the COSE study, they have regression of fibrosis in diabetes, patients with diabetes, but the number was very small.
So it's a really good, so I think there's this debate. I think most people believe that if you improve liver injury, i.e. NASH, that will have a beneficial effect on fibrosis. But what we don't know is how long that takes to materialize. Because, for example, if you take hepatitis B, we know that if you give patients who have hepatitis B and cirrhosis, if you give them, I think it was tenofovir, over a 5 to 10 year period, you see resolution of the cirrhosis. So A, we know it takes 5 years. B, we know that with the antivirals for Hep B, you can stop injury completely. So what we need to understand is in the setting of NASH, how effective does the therapeutic for the inflammation need to be before you start to see the effects on fibrosis? It may just be that, resolution of NASH takes longer before it starts to translate into improvements in liver fibrosis. And I think that's probably the reason why the FDA and the European Medicines Agency don't accept NASH resolution as a licensing endpoint. They view that as an unvalidated surrogate, which is why the phase 3 trials need super hard endpoints: death, becoming or not becoming cirrhotic, and complications of chronic liver disease.
So, Professor Philip, then which is the best drug option for this case? Which is the best or best treatment for this case presented by João Marcelo?
So that was the first one, the one that had cirrhosis. I think it's conservative management. I think it's trying to improve function. We know that improving physical function helps. That improves muscle insulin sensitivity. I think it's the diet. The dietary advice becomes a little bit more nuanced. It's not just about reducing body weight. It's around reducing body fat and increasing lean muscle. So it's that combination. But in terms of drug therapies, I would manage the metabolic syndrome as appropriate. So manage blood pressure, dyslipidemia, etc. I can't remember if they were diabetic or not. If they were diabetic, you might want to consider an appropriate agent, a weight neutral agent. But I would not use a liver-specific pharmacotherapy because I don't think vitamin E or pioglitazone are appropriate in this setting.
Don't you feel yourself attempts to use vitamin A based on the study you just presented?
So I think the data are interesting, but I don't think that's a sufficiently rigorous. It's not a randomized controlled trial. It's a retrospective, non-randomized study. And I think, Naga Chalazani is an outstanding researcher, but you can't always adjust for things because you don't know what else to adjust for. And that's why we do randomized trials. So I think that that would be the reason why I wouldn't use it. But I'd be interested to hear whether Mohammed's view is similar or different.
No, I agree. I think it's a retrospective trial, and the data is limited. So using vitamin E, I'm not sure it's warranted in literature. The other thing, as you mentioned, Dr. Newsom, is that these patients with NASH are particularly prone to sarcopenia and muscle loss, particularly as disease progresses. And in cirrhosis, sarcopenia or muscle loss is a key predictor of outcomes in death. So focusing efforts in improving things that we can actually improve, and there's data behind, like muscle mass, would actually where I would put all my efforts into. And then obviously making sure that the portal hypertension related care is up to date. So ultrasounds and HCC screening, endoscopies, and so on.
Natalie, Arun sent me a message now that he's still in the meeting. And all his talk to us early in the morning. I think he could not enter in the room so far. I'd like to ask the question for his talk for both the speaker and the Brazilian speakers as well. What do you think NAFLD against MALFD? What's the name? Can you comment, Siddiqui, Felipe, and the others colleagues from Brazil? It's very polemic, but I would like to listen to their opinion.
Leila, because I'm co-author with my paper, I am stay quiet here.
Well, maybe I can just set the scene. So I think there's a couple of points. The first thing is that there has not been a name change. The second thing is that the four major liver societies, so EASL, ASLD, ALE, and PASSO, have convened a kind of working process which will end up with a consensus meeting, which will discuss, amongst other things, the nomenclature and whether or not there should be a change or not. I think it's fair to say that there are differing views on that. I think everybody accepts that non-alcoholic fatty liver disease is not a great name. It's a negative name. Can you drink too much and have NAFLD? Well, you can't, because the definition says you can't, but you know full well that somebody can be overweight, diabetic, and drink too much. So I think there are challenges there. I think the patient groups give you different views. Some feel that it is stigmatizing because the first thing they say is, but I don't drink. And even though you've said non-alcoholic, the word alcohol is all they hear. So that's what the discussion will hopefully arrive at a consensus, but you don't always achieve consensus, do you? So we'll see.
Adar, would you like to comment something about this, please?
Yeah, I agree. I think we all sort of, we could improve on the name because obviously NAFLD is a diagnosis of exclusion. And there's a lot of overlap with other diseases that Pranusa mentioned. And sort of abandoning NAFLD, I think it's still too early. And I think we need to sort of wait.
Elma in Parisi, Brazilian, comments for them?
I would like to comment it because I'm also co-author in the Latin American guideline about this. And maybe after that, I agree with the last article in Hepatology in March about maybe it is premature to discuss it now.
Well, I have mixed emotions about this. First of all, it's very positive that we have a way to do diagnosis, not to deny a diagnosis. That's very clear for me. And we have dealing with epidemiological study at the moment with more than 4,000 of patients that have assist to a checkup, exams during a long period of time. And we first classify they as NAFLD and then as MELHOR. And we lose less than 10% of the patients that has steatosis. What seems to me, that's a very good point because there is no such difference, but we are doing the diagnosis in a positive way. And I think this is better for you to have. The other thing is that this new definition englobes patients that we clearly see that they behave different. For instance, people who drink a lot, but you see that they behave much more like a metabolic disease than an alcohol disease. And we have already seen this in hepatitis C clearly, that patients with genotype 1, they can differ completely if they have insulin resistance or not. So I think this is one step forward in the disease. And we could, of course, we have a lot of empty spaces that we have to fulfill, but I think this was a good start of the game. Claudia?
For my view, I agree, of course. I'm co-author the Journal of Hepatology paper, but I not agree with the inclusion of some diseases such as autoimmune hepatitis and viral hepatitis. So in the panel, I said I disagree with this, but in the relation of alcohol, I think that's okay. MELHOR and if alcohol is associated. So, and I think that we need to improve to the Nash definition or MASH definition, a histological definition inside of MELHOR. This is my opinion about MELHOR definition.
Okay, Natalie, I think the time is over.
Okay.
The professor would like to be, I'm going to put on the site end of the meeting. And I'd like to say thank you very much indeed for Philip, for Mohammed, for all my Brazilian colleagues, Elma, Claudia, Parisi, Rosamar, João Marcelo, still enjoying Fernando de Noronha. Philip, Fernando de Noronha is a great island in the nearby Recife. It belongs to Pernambuco state. and you have held our meeting for 3 times in this paradise island, but for the COVID pandemic, we couldn't do this in Fernando Noronha this year. That was our plan before. But one day we come back to Fernando de Noronha to show that you could join a scientific program with some, could I say, some drinks and foods and beach together is a very nice
place.
Okay.
Sounds lovely.
Natalie, thank you very much indeed for your co-share with me. And
thank you, Leila.
Thank you very much for all the participants. We have 1,864 participants online in the webinar and 210 in the room. Thank you very much indeed. See you next Tuesday.
Congratulations.
Congratulations. I want to say it was good to see Dr. Mohammed again and to see that's the really nice presentations, because a surgeon's still in the room looking at it until now, okay? So okay. Professor Philip, in the end of the month, I will be at King's College working for 2 years. So hopefully I can give you a hug personally in Birmingham. And I sent some greetings from my friends, surgeon friends that spent 5 years there, Amanda and Yuri. They say hello from Brazil.
Great. Thank you.
Okay, bye-bye.
So much.
João Marcelo.
Bye-bye. Bye-bye.
Bye.
Obrigado.